So, very good evening, everyone. Hope you all are doing well. In today's session, which is my lecture number 98 of my lecture series, I'm going to discuss with you all via case-based approach the Endocrine Society Guidelines, which were released in the late December 2022 and published in the JCEM in the 2023. So, I'm going to do that through case-based approach, and let's start right away. So, as I mentioned, this was published in JCEM in March 2023. So before you listen to this lecture, make sure that you hear my initial lecture on hypercalcemia, where I had discussed around four case-based scenarios to approach hypercalcemia, where I had talked in detail about PTH dependent and PTH independent hypercalcemia and how we need to investigate and the approach to high calcium in clinical practice. It's a very important session to understand the differentials. This was a very popular lecture in my initial lecture series. So it's all part of my lecture series. All right. So let's start right away with this latest update for malignant hypercalcemia in adults. So the case scenario one pertaining to this Endocrine Society guideline, we have a 70-year-old female with parathyroid cancer, had hypercalcemia, so significantly elevated calcium levels around 3.2 millimole per liter, which is around 13.2 milligram per deciliter. That normalized post parathyroidectomy. But her serum calcium increased again 4 months later. 2 weeks ago, she was then admitted with symptoms of hypercalcemia, nausea, polyuria, and also she had some weight loss. Her general condition was seen to be poor. She had height of 146, weight of 44, heart rate of 76 beats per minute, and blood pressure was stable. Her serum calcium was again found to be elevated almost to the initial levels which were before the surgery. It was around 13.4 milligram per deciliter this time. And again, the intact parathyroid hormone was up at 603 with the normal range of 10 to 65. So, of course, with the initial management, as was discussed in my initial lecture of hypercalcemia, the patient was started on IV hydration with saline, and the serum calcium slowly decreased, dropped down to 11.9 milligram per deciliter from the 13.2 over the period of 2 days, and then showed minimal fluctuations thereafter. She showed mild to moderate improvement in her general condition and was subsequently discharged from the hospital. Extensive imaging investigations did not show any clear evidence of recurrence, so currently no surgery was indicated. So, which of the following therapeutic options from the options given here will you consider at this stage? So, remember, patient had already got the IV hydration. So, should we just continue the IV hydration? Should we increase our hydration further? Should we add an oral calcium mimetic at this point, or should we start the patient on oral bisphosphonates? So, what do the guidelines suggest? The best choice answer here will be to start a oral calcium mimetic. This is effective for reducing hypercalcemia and is FDA and EMA approved for parathyroid carcinoma cases as this patient. It is also approved for other indications like secondary hyperparathyroidism associated with renal failure and severe hypercalcemia in patients with primary hyperparathyroidism who are unable to undergo parathyroidectomy. So what is this calcium mimetic agent we are talking about? It is cinacalcet. It is given in the following doses of 30 milligram twice daily, then increased every 2 to 4 weeks through sequential doses like 60 milligram twice daily, then 90 milligram twice daily. It can go up to 90 milligram 3 to 4 times really as needed to normalize the serum calcium. Remember, the onset of the action is around 2 to 3 days time. So it's very important to understand for cinacalcet. Common side effects, hypocalcemia and anoschias, isolated idiosyncratic reactions can occur, leading to hypertension, worsening of heart failure, and or arrhythmia. Adynamic bone disease can develop if intact parathyroid hormones are oversuppressed. Hepatic impairment can occur as well. The most commonly reported adverse events, which occurs in more than 5% incidence, is nausea, vomiting, and diarrhea. This was actually a question in the previous specialty and European board exams. Of course, in the other options, the patient is already getting hydrations, and the other options will not be appropriate. So, going further, The patient was started on cinacalcet as we selected from the options. The dose was progressively increased to 60 milligram twice a day. The dosage was well tolerated, leading to a gradual decrease in the serum calcium to around 10.8 to 11 milligram per deciliter. After discharge from the hospital, serum calcium actually remained stable for the next 3 months. Then again, the recurrence happened. Then again, it was increased to 12.5. The daily cinacalcet dose was adjusted further from 60 milligram BD to TID, but the GI adverse events limited this, and hence we had to reverse back to 60 milligram BID. The patient was admitted to the hospital with symptoms of nausea, vomiting, polyuria, fatigue, and again deterioration of a general condition. Again, symptoms of hypercalcemia back. Her body weight was further down. Serum calcium this time was significantly elevated at 16.1. And at the same time, her kidneys were getting affected. Her creatinine clearance had dropped down to 227 milliliter per minute, and the creatinine had gone up to 1.3 milligram per deciliter, which was clearly elevated. Again, as a protocol, patient started on IV hydration, and this time, in addition, patient was also given subcutaneous salmon calcitonin injections. This is given at the dose of 6 IU every 8 hours. On the following day, serum calcium then declined to 13.9 milligram per deciliter. So, what is this salmon calcitonin? It inhibits the bone resorption via interference with osteoclast function. It promotes urinary calcium excretion. It can be given intramuscularly or subcutaneously. Initial dosing is 4 units per kg. Serum calcium is repeated every 4 to 6 hours when receiving this serum salmon calcitonin. If a hypocalcemic response is noted, then the patient is calcitonin sensitive, and calcitonin can be repeated again after 12 hours for a total duration of up to 24 to 48 hours. This is very important. If the response is not satisfactory, the dose may be increased to 8 units per kg every 6 to 12 hours. Again, total duration of therapy should not exceed 24 to 48 hours. The efficacy of calcitonin becomes limited after 48 hours, even with repeated doses, indicating development of tachyphylaxis, which is due to receptor downregulation. So, this is important. Efficacy is limited beyond 24 to 48 hours. So now, which of the following therapeutic options will you consider at this stage? Should we increase cinacalcet to 60 milligram TID? Should we add loop diuretics? Should we start IV bisphosphonates, or should we consider starting subcutaneous denosumab? So at this level, where the serum calcium has again elevated, creatine clearance has dropped, what is the best choice to consider at this stage? So from the guidelines and from the options provided, denosumab, which is a fully monoclonal human monoclonal antibody that binds to the rankle ligand. Again, a very important mechanism of action asked frequently in the exams. Inhibiting its binding to rank receptor and on the osteoclast precursors and the mature osteoclast. This process prevents osteoclast differentiation, activation, and function. Now, due to concomitant kidney failure, of course, denosumab is the drug of choice over bisphosphonates because we cannot use bisphosphonates in this context with such a reduced creatine clearance. Things to keep in mind for denosumab, of course, for hypercalcemia malignancy, it can be administered 120 milligram every 4 weeks with additional 120 milligram doses on days 8 and 15 of the first month of therapy. For other indications like multiple myeloma and bone metastasis from solid tumors, it can administer 120 mg every 4 weeks as a subcutaneous injection. To keep in mind, hypocalcemia as a warning and precaution, osteonecrosis of jaw, and atypical femoral fractures. Again, GI adverse events often prevent increasing the cinacalcet dose to maximum allowed, as we have already seen in the first question stem. Further, calcitonin lowers serum calcium within 14 to 24 hours, but effect is modest and is lost within 2 to 3 days due to tachyphylaxis. That's why it rules out the other options in the question stem provided. Over the next 4 days, serum calcium declined further to 12 milligram per deciliter. IV hydration was progressively reduced and eventually stopped. Serum calcium further decreased down to 8.2, which was excellent, and the patient was discharged. It was then recommended that denosumab be repeated every 4 to 6 weeks based on the serum calcium levels, with consideration for a lower dose due to reduced creatine clearance and risk of hypocalcemia. And that's the end of my freeview. Now, in this particular session, I have discussed total of around 6 clinical cases, case-based scenarios to cover the guidelines. If you like access to this full session, please subscribe to my lecture series. Of course, this lecture series has around 98 lectures so far. With the one-time subscription fees, you can gain access to the full 98 lectures plus all the upcoming new lectures and videos on my channel. So thank you so much. Hope you enjoyed this session.